All right, and you can unmute yourself.
Yeah, that's kind of important. Okay. Can everyone see me and hear me?
Yep.
All right. Yeah, so I'm going to talk to you today about allergic reactions to the COVID-19 mRNA vaccines. And we've seen some cases, there have been very, very few cases, but we have seen cases of allergic reactions, specifically anaphylaxis to the COVID mRNA vaccines. And it's been suggested that this is due to the nanoparticle formulations that both Pfizer and Moderna have used. And I think it's important as part of the nano community to think about why this is happening and potentially if this could inform the rational design of our nanoparticles, and also because this is a concern for the general community and the safety of the vaccines. So just as a quick outline, because it's going to be a very quick talk, I'm just going to first start with the Th2 response. What anaphylaxis can occur via IgE dependent and independent mechanisms. Then I'll talk a little bit about what we've seen with the vaccines triggering anaphylaxis in a small number of people, and how pegylation is likely the trigger for these anaphylactic reactions to the vaccines. Then I'll talk about some putative mechanisms of how anaphylaxis is happening via both IgE dependent or independent mechanisms. And lastly, some implications for us and how this could inform our rational design of nanotherapeutics. And then I'm going to end with some mind candy on allergy and evolution. So just to jump in, anaphylaxis is a serious generalized or systemic allergic or hypersensitivity reaction that can be life-threatening or fatal. And this slide just shows the pathophysiological changes during anaphylaxis and some of the mediators that have been implicated. And as you can see, the symptoms are hives, redness, rash, swelling, airway obstruction, nausea, and diarrhea. And the first line therapy to counteract these pathophysiological changes is, of course, epinephrine or the EpiPen, right? And this induces vasoconstriction that diminishes the edema and hypotension. It increases your heart rate and dilates your airways. And it also can directly block histamine release from mast cells and other effector cells that are causing these pathophysiological changes. So how does this happen? So first I'll talk about this IgE dependent anaphylaxis that could occur. And this is like the classical definition of anaphylaxis, where your immune system encounters an allergen that is then presented by antigen presenting cells like dendritic cells, and it triggers the stimulation of Th2 cells. And these Th2 cells can then trigger class switching of B cells so that now these B cells produce IgE antibodies that are allergen specific. So IgE dependent anaphylaxis requires a sensitization event. And once you've been sensitized, if you are re-exposed to the allergen, this triggers the IgE antibodies bind to the allergen, and then the antibodies can then cross-link on the surface of mast cells and basophils. They bind to their receptors, and that cross-linking to their receptors on cells triggers degranulation of mast cells and basophils and the release of histamine, tryptase, and other mediators that trigger those pathophysiological changes that I showed you before. Anaphylaxis can also be induced by IgE independent mechanisms. So although these are far less studied and we don't know the exact mechanisms, it's been reported that IgG antibodies can bind to drugs and other things that trigger neutrophil mediated anaphylactic shock. There can also be direct complement activation. So it's even been shown that some nanoparticles can directly activate the complement cascade, and components of that complement cascade, specifically C3A and C5A, are considered anaphylatoxins. So they can directly trigger the anaphylactic shock. There's also something called non-immunologic or drug-induced anaphylaxis, which is where the drugs directly bind and activate mast cells, leading to degranulation and anaphylaxis. And what's important to note with what I've showed you before, the IgE dependent and IgE independent anaphylactic reactions, is that they're clinically indistinguishable. So if someone is having anaphylaxis, it's impossible to know what the mechanism is by what they look like. So what's happening, what do we see with these mRNA vaccines? So this just came out in JAMA, and it's based on data accumulated up until January of last month. And what we're seeing is that the Pfizer vaccine has about 4.7 cases per million doses and 2.5, Moderna has about 2.5 cases per million doses administered in terms of anaphylaxis. So this is still a pretty small number if you think about it. But anaphylaxis occurs around 10 minutes after vaccination, so pretty quickly. And 92% of the patients that had confirmed anaphylaxis were treated with epinephrine. And of those that had anaphylaxis, 32% of them had a prior episode of anaphylaxis. And so these prior episodes were triggered by anything from jellyfish to penicillin to unknown. And I want to reiterate that these cases of anaphylaxis were deemed anaphylaxis and confirmed by this Brighton collaboration case definition. So there's strict guidelines by whether they consider this true anaphylaxis. But how does this compare to other vaccines? So if you look at the flu vaccine, it's only at around 1.3 cases per million, and that's similar to the DTaP vaccine. And you see a higher number of anaphylactic reactions with the MMR vaccine, so somewhere between 3.5 and 10. And you see a bigger range here because they're using some more promiscuous criteria to determine whether something is anaphylaxis or not. And it's important to note here that the vaccine allergies that we see are typically due to the inactive ingredients or the excipients like egg and gelatin and other stabilizers that are in the vaccine, as opposed to the active ingredient. So what is triggering anaphylactic responses to the COVID vaccine? So if you look at on the CDC website, they say that if you've had a previous allergic reaction to any component of the mRNA vaccines, especially including polyethylene glycol, PEG, or if you've had an allergic reaction to polysorbate, that you're contraindicated to taking this vaccination. And so if you look at both vaccines are formulated with pegylated lipids. But just if you look at the list of ingredients here, it's possible that there are other things that could be triggering anaphylaxis. We don't know for sure. Lots of these salts and sugars and buffers are used in a bunch of different formulations, and it's possible that you have antibodies against other components. But by Occam's razor, and I'll show you why in a second, the putative culprit is pegylated lipids. And so why is that? So if you looked, we've actually observed anti-PEG antibodies for decades now. So starting in the 50s, we saw that there were immunological reactions to PEG that caused blood clotting and cell clumping. Back in the 80s, there was a study that showed that 50% of allergic patients that were treated with monomethoxy PEG modified ragweed extract or honeybee venom developed anti-PEG IgM. But they kind of dismiss this because it's not clinically relevant. It's not been shown that IgM is clinically relevant for allergic responses. But it's important that these antibodies were also present in a small 0.2% of healthy donors as well. Then you fast forward to 2009, and a study showed that 27 to 28% of healthy individuals had pre-existing anti-PEG IgG and IgM. So it's much larger. And currently, it looks like 70% of patients that are treated with pegylated therapeutics will develop anti-PEG IgG. And this has implications for efficacy as well. There have been a number of studies that have shown that anti-PEG antibodies can inhibit the mobility and biodistribution of pegylated nanoparticles in vaginal mucus. But one thing to note is that just because you have antibodies doesn't mean that you're going to have an allergic reaction. So it's possible to have anti-PEG IgG and IgE and not have any clinical symptoms. But why do we see this huge increase in anti-PEG antibodies? Well, one possible reason is because PEG is everywhere. So it's in your toothpaste, it's in your mascara. Hopefully you don't need to use it, but it's in your Miralax. And it's also in a lot of common injectable medications that contain PEG. So it's also in 30% of tablets as well. So it's not surprising that we see some sort of reaction to PEG. The CDC also mentioned polysorbate, and it turns out polysorbate is an excipient in the AstraZeneca and J&J vaccines. And polysorbate is structurally very similar to PEG, and it turns out that if you have hypersensitivity to polysorbate, that's actually cross-reactive with PEG. And I don't want you to look too closely at this table, but my point here is that polysorbate has been used in a number of vaccines already. Whereas this is the first time that pegylated lipids are being used in a vaccine with the Moderna and the Pfizer vaccines. Okay, so what we see is antibodies, but what is the true immunologic or immunogenic or allergic potential of these antibodies? What do we actually see? Well, it turns out that human allergies to PEG they're not a new concern. So anaphylactic reactions to pegylated meds have been seen with pegylated interferon alpha and GSF, and with pegylated liposomal doxorubicin, so Doxil. Here, there are infusion reactions in up to 40% of recipients, and it's been shown to be driven by complement. So that's where it's not IgE dependent, but the hypothesis is that there's some sort of direct complement activation which occurs on the first infusion. And with subsequent infusions, that response is actually attenuated. So that's one possible mechanism for what's happening. Other things that we've seen, the risk of sensitization appears to be higher with injectable drugs that have higher molecular weight PEG. Then there's also anaphylaxis that's associated with bowel preparations containing PEG. So there was a case report that a patient was given a PEG bowel preparation and had anaphylaxis. And then a bit later, they had another episode of anaphylaxis when they were exposed to this pegylated echocardiography contrast. And when they looked at their plasma, they showed that they had IgE antibodies against PEG. So what are the putative mechanisms of some of these PEG allergies? There's a lot out there, but one potential sensitization scheme. So this is when you require a sensitization event and then you trigger this IgE dependent response. So one possibility is that low molecular weight PEG could penetrate skin and mucosa to a greater degree, increasing your risk of sensitization. And if you have injured skin or mucosa, and that's how the PEG is getting in, some sort of local inflammatory response could be triggering this sensitization event. So almost like PEG is like a guilty by association, right? And if you clean a wound or something like that with a cleaner that has PEG, then you're also adding some sort of persistent exposure. And I have also showed you that there are a lot of healthcare products that contain PEG. So with that persistent exposure, then if you are exposed to a higher molecular weight PEG and you already have IgEs that are anti-PEG, it's possible that that triggers a multivalency that lowers the threshold for triggering an IgE-mediated hypersensitivity. It's also possible that there are lots of papers showing that surface charge, morphology, and size can trigger complement activation. It's also been shown that lipid nanoparticle aggregates, PEG lipid micelles, and pegylated vesicles can trigger the release of the cytokine IL-33 from macrophages and damaged epithelial cells. And IL-33 binding to its orphan receptor on mast cells can trigger degranulation and anaphylaxis. And this lipid nanoparticle aggregate idea is kind of interesting because before the Pfizer vaccine came out, they had actually observed some visual particulate matter in some of the finished product batches. So it's possible that there is some sort of precipitation or aggregation that's happening. And upon injection, that could be triggering a local inflammatory event that triggers an anaphylactic response. Okay, so what should we think about as the nano community? So mechanisms behind these allergic host defenses could inform the rational design of therapeutics. So I think some important questions to ask are, what are the mechanisms leading to healthy versus hypersensitivity responses in humans? Like, why is it that some people can have these antibodies and no clinical symptoms? And why is it that some people have this hypersensitivity? And what factors could be predisposing individuals toward mounting anti-PEG antibodies? And we're hopefully vaccinating most of the population with these COVID-19 vaccines. So will anti-PEG antibodies reduce the efficacy of pegylated therapeutics in the future? And will PEG allergies be a bigger concern after COVID-19 vaccination when we perhaps have sensitized a large number of people? And I think that it's important for us to develop some sort of reliable and preferably rapid in vitro test for PEG allergies, and some sort of in vitro test to do this could actually help us design some sort of framework to design and evaluate nanocarriers. And so almost be like, okay, what are the chances that this carrier could induce either antibody responses or some sort of anaphylactic response? And this could also inform the design of substitutes for PEG, which a lot of people are already thinking about. So these are some of the questions that I wanted to discuss after if there's time. But I wanted to include one more thing, which is kind of my mind candy for all of you to go home with about allergies and evolution. And a lot of people have think that allergies are simply just a biological mistake or an evolutionary mistake, that, oh, we used to have parasites, now we don't. So now we're accidentally attacking all these innocuous agents in our environment. But is this truly just a biological blunder, or is it an actual protective mechanism? So I'd like to discuss this quickly by sharing some information, some data that we know, and some ideas. So back in the 70s, Bridget Ogilvie showed that rats that were infected with parasitic worms triggered large amounts of IgE that unleashed a damaging assault on those parasitic worms. And one of my mentors, Ruslan Metsitov, and Stephen Gawley have both demonstrated that IgE antibodies and the proteases that are released from mast cells can actually protect against the effects of bee venom and snake venom, and these would otherwise be fatal assaults. But then you have these agents like pollen or dust mite allergies, right? Which are seemingly innocuous things that are triggering allergic defense mechanisms. So why is this, right? Why is this happening? What do all of these have in common? And you know, there isn't really a molecular counterpart for parasites in pollen or dust mite allergies. That can't be the only reason. And so why is this happening? So one hypothesis is that it's not about what they look like or their shape or structure. It could be what they're doing in the body, right? So if they're all triggering similar damage or cell lysis. And another analogy of thinking about this is if your house is being robbed. So if your house is being robbed, one way you know your house is being robbed is that you're looking at the dude that's robbing your house. Another way you could know that you're being robbed is that your window's smashed and your stuff is strewn about. And then it's kind of an indication that you've been robbed, and then you mount some sort of defense by calling 911 or installing ADT, right? So, so the immune system works very similarly. And we actually already know this for viral infections and bacterial infections, where the immune system is able to detect the activity of viral proteins and bacterial proteins. So when those activities trigger damage, then we mount a response. So the immune system already knows how to identify various signs of an intruder. And so these TH2 responses or allergic responses are probably no different, where all of these things might be triggering various levels of cell lysis or membrane damage, and that triggers allergic host defenses. Okay, so yeah, but what about anaphylaxis? Why are we triggering anaphylaxis to an mRNA vaccine? Or why are we triggering these hypersensitivity responses? Well, one could argue that hypersensitivity in some individuals, due to their life history or due to genetic mutations, is a small evolutionary cost that we pay for evolutionary benefit that has been around for probably millions of years and has helped our ancestors survive. And by mounting allergic host defenses, and the discomfort associated with it might have promoted our ancestors to move away from more dangerous environments to safer environments. But these days, of course, we have a lot of synthetic compounds, and these synthetic compounds might be doing membrane damage. So we already have some, I've talked a little bit about how we know that maybe these lipid nanoparticle aggregates are triggering some sort of damage and complement, or you know, we don't know yet, and things are a little different now. We don't move to a new location when we have allergic responses. But basically the take home here is that perhaps that allergies are not an evolutionary mistake, and that at baseline, they're normally just allergic host defenses that help us. And once in a while, that they can trigger anaphylaxis, and it was just an example of an exaggerated response. And this is very similar to the fact that inflammation is good for you, but chronic inflammation is bad. Pain is a good thing, but chronic pain is bad. So similarly, you know, these TH2 responses under normal conditions are protective, but once in a while they can go awry. And understanding the mechanisms of these could help us hopefully design better nanotherapeutics. So with that, I'd love to take questions, or I'd love to hear your thoughts on all of this.
Oh, thank you very much. I mean, I think we have a question from Vijay. Go ahead, Vijay.
Hi, thanks for the talk. I read a paper years and years ago. It was just one small paper that tested Doxil as an infusion versus, I think, just a bolus injection. And they found that they got allergic reactions, immunogenic reactions against Doxil only with the infusion group. So have you seen anything similar in your review where they found that it's not just the material or the dosage, but also how the material enters the body that determine allergic triggers?
Yeah, absolutely. And so you see most of these allergic reactions when it's actually in the blood circulation, as opposed to if it's intradermal injection or if it's topical, right? Most of this is that there's some interaction with the circulatory system. And it's also, I think they did a similar study with pegylated interferon versus interferon. There have been a number of studies that have compared these allergic reactions. So definitely location matters, and what kind of cells are seeing it and perceiving this danger. But then I'm not sure whether the bolus that they injected, was it the exact same thing that they injected as a bolus, or were they still pegylated or not?
It was the exact same formulation.
Yeah, so in that case, location definitely matters, and we see that with a lot of these allergic responses. So they're, usually, and the hypothesis with a lot of the allergic responses that happen with oral medications is also that there's some sort of epithelial barrier breach that helps something get into the bloodstream. So definitely location matters.
And the other question was, do you know if the Pfizer's COVID vaccine has more PEG content than Moderna's? I think Moderna's has like 1.5 molar ratio of DMD PEG. I don't know if we know anything about Pfizer.
Yeah, offhand, to be honest, I don't remember how much. I don't.
Okay. Yeah. All right, thank you.
Oh, thanks.
Thank you, everybody. Thanks so much for attending today. I'm going to wrap it up. Padmini, Leanne, that was amazing. Thank you so much. We'll see you in March. Bye-bye.
Thanks.
Thank you.